Welcome back to part 2 of our 3-part series where we continue exploring the world of medicine through the lens of top experts. Let's dive in.
So,
Absolutely.
Zoe, you were one of 3 authors on a paper, What's New in Osteoporosis Management, Leading the Fight in Primary Care. It was published a while back. Can you discuss some of the latest or most exciting advancements in the field of osteoporosis treatment and how that will impact primary care?
Yeah, I think there's been a real uh, culture shift really in the last 3 years in the medicines that we use to strengthen bone and lower the risk of fractures because 4 years ago and more, it was a kind of one size fits all approach where we used drugs called bisphosphonates as first line by tablet form for everybody, unless there was a reason why that wasn't a good idea. And so the people who got referred to secondary care were the people who couldn't have those medicines, or perhaps had had those medicines for some time and there was a feeling that they perhaps weren't really working. So 3 years ago, NICE in England approved a drug that works differently called romosozumab, which builds bone strength rather than just sort of stopping it getting worse, which is really what bisphosphonates do. They do strengthen bone a bit, but they're mainly stopping the process of bone loss. And when they approved that drug, they approved it for first line use, which was a complete change in what we're doing. So we now need a much more stratified approach where we're thinking about who is at the highest risk at point of diagnosis or at point of first thinking about a medicine. Um, and really, a large part of that is people who've got spinal fractures already, because we know they're at the highest risk of further fractures. And actually, the medicines are all best at lowering the risk of spinal fractures. So we're now really trying to get our heads around what this means for practice. And it's got huge implications for primary and secondary care because we want primary care colleagues to refer more people and be thinking of this medicine. I should say that romosozumab is not the only medicine that's anabolic. There's 2 others, and there's been another NICE guidance since then, but which again is similar and approving, first line use of an anabolic drug. So um, it's meant a complete change in pathways, and I think we're all still catching up and dealing with that. Nobody's got it sorted yet. This is going to take a bit of time because it's really causing quite a seismic shift in the way care is delivered, and the patient
Mm.
numbers are vast. So it's how we cope with that.
Yeah, sure.
Yeah.
Sure. But I mean, I'm a bit surprised that despite what you told us about the screening numbers, that it wasn't considered sufficient evidence. I, you know, I'm a surgeon, so I have a sort of surgical mentality. I want the best evidence available today, and if better evidence comes along to change course later, I'm fine, do it. But I like taking action. I can't stand pontificating. I guess that's why I did surgery. Um, and I, recently I got a phone call from a friend that he and his wife were up in London staying at a hotel. And middle of the night, his wife goes to the bathroom, falls, fractures her hip, although she probably fractured her hip and fell. And you'd look at this woman, you'd say, this woman she's the poster child for osteoporosis.
Mm.
So she goes, I help get her seen. Lo and behold, she's got profound osteoporosis. And the doctor I spoke to, who was looking after her, said that the philosophy now is to wait for an index fracture. And I practiced, as I say, half my career in the United States, where, and again, it wasn't across the board. And you're absolutely
Mm.
right. The people who probably need to be screened don't get screened. It's the worried well who get
Mm.
screened. But screening was much more widely available. And in fact, my late mum, I had to push to get her screened. She was again a poster child, and she had profound osteoporosis. And her GP was very irritated with me when I was nagging, can you please screen her? And then, having screened her, after a few weeks of treatment, the GP wanted to stop treatment and said she's fine now. Well,
Mm.
even though I'm just a simple surgeon, that's not the case. How do we change our thinking? How do we be a little bit, or am I completely out of order here? Which is entirely possible. I often am.
I don't think you're out of order. No, I think I share a lot of your views here, but I think we are where we are for a number of reasons. And, I've mentioned some of them already, but I think because we don't have this robust enough research evidence that this approach saves money, it is not prioritised in the NHS at the moment, in the UK certainly, and I think in other countries as well. So, unfortunately, our prioritisation and the financial system that goes around that in primary care has really driven care. So I think that osteoporosis has got left because of that. So I believe to change that we need the research evidence. The other two things that are really important are this societal normalization of aging and the muddle about people not really understanding what osteoporosis is. And then the third thing is that I think this is something that we've come to understand quite recently from our work with health professionals, trying to understand what are the barriers, why is this so difficult, what's going on, is that actually, osteoporosis has probably been viewed by healthcare professionals as something in the past that was quite easy, but actually it isn't. And I think we've surveyed and interviewed, getting on for 400 healthcare professionals in primary care now. And the clear message that we're getting is this is actually really complicated, and they've got lots of clinical decision making needs around it. They find it a muddle. The clinical guidelines aren't helping them. And actually, they probably, even within primary care, need people who've got that sort of specialist interest to be sort of driving and championing this forward. So I think if we can tackle all of those things, societal views and awareness and a clear understanding, getting the research evidence to really prioritise it in policy and help clinicians with the decision making, then I think we'll have sorted it out. So that's my life's work for the next 20 years.
And that's a wrap on part 2. Thanks for tuning in. Don't miss the third and final episode where we conclude this deep dive series.